Yeah, hello, Dr. Asutosh. Good evening.
Yeah, I'm there. But is the student there?
Yeah, Dr. Bhargav is with me.
So, okay, so we can start the presentation.
Yes, sir. Yes, sir. So, welcome, students. The exam is very near. Nothing to worry. So, today we have two presentations. One is the case presentation on how to evaluate the neck nodal mass with neck node examination, very important topic. And after the 1 hour, we will have the another session on chemotherapy identification and chemotherapy related questions. So, don't miss the opportunity to learn. And Dr. Ashutosh Mukherjee is the moderator for the case presentation. He is the head of the radiation oncology in Tata Memorial Hospital, Banaras. And presenter is the Dr. Bhargav Krishna from Mahatma Gandhi Cancer Hospital, Visakhapatnam. So, without any delay, let's start the presentation. Over to Dr. Ashutosh.
So, good evening, everyone. So, today we will have a case presentation on a patient presenting with a isolated neck node. So, this is quite a common presentation across the country, and it offers us a varied differential diagnosis. So, I'll ask Dr. Bhargav first to present his case, and then we can have a short discussion. I think now in DNB, the new pattern, there are no long or short cases. So all the cases are equally marked. So it should be a general, it will be a full, you can say a full case.
It
So
will be a full case.
it will be a full case. It's not just a short case. And Dr. Bhargav, you will have to present it as a full case and take into account all the differential diagnosis. So over to you, Dr. Bhargav.
Yeah.
Yes, sir. Yes, sir.
From Clarinet, please start the recording. Recording. Oh.
Good evening, sir. I am presenting a case of a 39-year-old female, premenopausal female, Mrs. S, who is hailing from Barampur, Odisha, homemaker by occupation, belonging to lower socio-economic status. Presented with chief complaints of swelling over the right side, right lower neck region since 3 months. Patient was apparently asymptomatic 3 months back. Then she noticed a swelling in the right lower neck region. Insidious in onset, gradually progressing to present size. Initially in the size of a small marble, now progressed to the size of an orange. It was not associated with pain. There is no history of redness or ulceration and discharging sinus of the overlying skin. No history of any growth in the oral cavity, loose and sharp tooth, excessive salivation or foul smelling discharge from the mouth. No history of any ill-fitting dentures. No history of difficulty in swallowing, speaking and chewing. No history of decrease in the mouth opening. No history of change of voice or stridor. No history of ear pain, discharge and bleeding. No history of nasal blockage, nasal discharge, bleeding or headache. No history of difficulty in breathing. No history of any swelling or wound over the head or face and neck. No history of any breast lumps. No history of fever, weight loss and night sweats. No history of vomiting, hematemesis and early satiety. No history of chest pain, cough and hemoptysis, abdominal pain and distinction. There is no history of bleeding, PV and whitish discharge, and no history of any other swellings elsewhere in the body. Coming to past history, there is no history of any similar complaints in the past. No history of any comorbidities, no history of significant past medical and surgical history, no history of any hormonal replacement therapy. Her menstrual history, she attended menarche at 13 years of age. Her periods were regular for every 30 to 32 days and for 3 to 4 days of flow. Coming to marital history, she is married at 20 years. Her husband is shopkeeper. She denied the history of multiple sexual partners and venereal disease in the partner also. Obstetric history, she is G2P2L2 with 2 boys. Both are normal vaginal delivery at the hospital. First childbirth at 23 years and last childbirth at 25 years. Breastfed for both children for about 2 years. No contraceptives were used. Tubal ligation done after the last childbirth. Coming to personal history, she consumes mixed diet, normal appetite, bowel and bladder habits were normal, adequate sleep, no addictions, no history of any drug allergies. Coming to family history, there is no significant family history of any cancers. General physical examination. After explaining about the procedure and after taking verbal consent from the patient with female attendant nearby, I examined the patient in the well-lit room. The patient is conscious, coherent, and cooperative and well-oriented to time, place, and person. She is moderately built and well-nourished. Her ECOG performance status is 1. Her height is 146 centimeters, weight 70 kgs, BMI 32.8 kg per meter square, and body surface area is 1.6 meter square. She is afebrile with normal vitals. Her BP is in normal. BP is 120 by 80 with pulse rate and respiratory rate were normal. There is no history of pallor, icterus, cyanosis, clubbing, edema, and skeletal tenderness. Right level 4 cervical lymphadenopathy present, which is described in detail in local examination. No other lymphadenopathy elsewhere. Systemic examination, respiratory system. After sitting comfortable, she is having thoraco-abdominal respiration with symmetrical movement and no dilated or engaged veins. On auscultation, bilateral equal air entry present with normal vesicular breath sounds and no added sounds. Cardiovascular system, S1, S2 head with no murmurs. Central nervous system, her higher mental functions were normal, motor and sensory system were normal, cranial nerves were intact, no cerebellar and meningeal signs. Musculoskeletal system, limb movements were normal, no skeletal deformity, and gait was normal. Coming to parabdominal examination, inspection, abdomen is flat, umbilicus is central and inverted, no visible nodule at umbilicus. Skin over the abdomen is normal, no scars, sinuses, and engorged veins, no fullness or swelling visible over the abdomen and flanks. On palpation, the abdomen is soft and non-tender, no local rise of temperature, no ergonomegaly, no guarding or rigidity, no swelling palpated over the abdomen, no tenderness or swelling over the flanks. Her PVPR examination is normal. On percussion, no signs of any ascites. On auscultation, bowel sounds were heard and in normal in frequency. Coming to local examination, examination of the head and neck done in sitting position. On inspection, facial symmetry is normal. A swelling noted in the right supraclavicular region extending from the lower part of the neck to medial 1/3 of the clavicle. The swelling is globular in shape, size approximately 4 into 4 centimeters, smooth surface and margins are regular. Skin over the swelling is tense and shiny with no ulcerations and engorged veins and no visible pulsations. No any other masses or swellings are visible in the neck. Inspection of the oral cavity. Mouth opening is adequate. Oral hygiene is good. No ulcer or growth present in the oral cavity. No loss of tooth. No erythroplakia, leukoplakia, and submucosal fibrosis. Movements of tongue were normal. Tonsillar and soft palate symmetry is maintained. Inspection of the nasal cavity, ear, scalp, and salivary glands were normal. Bilateral breast is normal. On palpation, all inspector findings are confirmed. No local rise of temperature and tenderness. There is a palpable swelling over the right supraclavicular fossa lying lateral to the insertion of the sternocleidomastoid. The swelling is firm, non-tender, immobile, 4 into 4 centimeter swelling, which is globular in shape, smooth surface, and regular margin without skin pinchability. No impulse on coughing, pulsations over.
Hello?
Sir.
Yeah, please continue.
Yes, sir. Yes, sir. No impulse on coughing, pulsation over the swelling felt. No other lymph nodes and swelling are palpable in the neck. Carotid pulsation felt bilaterally at normal position. Palpation of oral cavity, tongue, buccal mucosa, upper and lower GBS, bilateral RMT, floor of mouth were normal. Laryngeal crepitus present. Parotid and submandibular glands are normal. Scalp is normal and bilateral breast is normal. So this is the video showing how I examine the neck nodes of the patient. The examiner has to stand behind the patient with we have to stabilize the patient head with one head and we have to start palpating the one side of the neck. We have to rotate the patient head to the side of the neck with on the side we are palpating so that the sternocleidomastoid become relaxed. So I will examiner has to palpate from the submental nodes, submandibular nodes, upper jugular, middle jugular, lower jugular, and the supraclavicular fossa. Then the posterior triangle neck has to be palpated. Summary: a 39-year-old premenopausal lady with no comorbidities and significant past history, complaining of right supraclavicular swelling since 3 months. On examination, firm, non-tender, immobile, globular swelling of size 4 into 4 centimeters palpated in the right supraclavicular region with involvement of the skin and underlying structures. Provisional diagnosis is malignancy of the unknown primary with the neck node. Clinically, TX, N3B, MX, the stage is up 4B.
Okay, so we have had a few questions in the meantime, and Thank you first, Bhargav, for the nice presentation. And the first thing is, in your obstetric history, you made one mistake, is it is not G2, it is P2L2, which G2 is if the patient is pregnant at that time.
Yes, sir.
Okay.
Yes, sir.
Secondly, any workup or investigation, even scopy or Hopkins examination or nasal examination, endonasal examination, I think should be presented as a after the provisional diagnosis of with a as part of the workup rather than as part of the examination. Okay.
Yes, sir.
Now coming to your examination technique.
Yes, sir.
Can you tell me the one big mistake that you were doing in the examination technique?
Sir, examination of the neck node, sir. Is it the examination of?
Yes, examination of the neck node. You showed the video only of the examination of the neck node, no? So examination technique. What was the one big mistake? It's a very small step, but it's a mistake.
The neck has to be flexed, sir.
Yes. So the neck has to be flexed and tilted to the ipsilateral side. Okay. So you were not flexing the neck.
Yes, sir. Yes, sir.
Secondly, have you you have not described the consistency? Have you described the consistency of the swelling?
Yes, sir. It is
You have
firm in
said
consistency, sir.
non-tender. You have said firm, non-tender, globular. So firm, non-tender. Was it stony hard? Was it woody hard? Was it a rubbery swelling? Was it compressible swelling or a non-compressible swelling? Okay, these
Yes,
are
sir.
important points. I think your SDAS will have these points. So
Yes, sir.
these points are essential when you have a patient presenting only with a neck node.
Yes, sir.
Okay,
Yes,
so
sir.
yes, someone is asking, can you be asked to do a Hopkins examination or a Thudicum examination or an IL examination? It can be asked from you. So you should practice all those procedures.
Yes, sir.
Then, so consistency will tell you whether it is a squamous cell carcinoma or it's a lymphoma, or even if it is a tuberculoma. It can be a tuberculosis also.
Yes, sir.
Okay.
Yes, sir.
Then staging. So since that is missing, so the staging itself will differ. So staging, you will say that I will then probably stage it after
Endoscope.
biopsy and an endoscopic finding. Okay.
Yes,
So
sir.
staging, yes, rubbery and lymphoma, definitely. So it can be firm to hard also. It may not be stony hard, but it can be firm to hard. And then question is, you have to you checked for the nodes, neck nodes, but you did not check for the post oral nodes or the pre oral nodes or the occipital nodes, because this is just an only neck node swelling, so you have to check for all the nodes.
Yes, sir.
So those were missing in your examination. Okay.
Yes, sir.
uh, then question is, um, movement of the swelling with breathing. So is the swelling associated with the breathing movement or with swallowing movements? So you have not mentioned that.
Yes, sir.
Hmm? Have
Yes.
you? I don't think you have.
It is immobile swelling, sir.
Yeah.
With
Then
swallowing
yes,
delineations.
as someone has said, trans illumination you have not mentioned. So that is also important. Trans illumination you have to do. So your examination was missing out on a few points. Okay.
Yes, sir. Yes, sir.
Okay. Then coming to your differential diagnosis. So what will be your various differential diagnosis? And also, I think in your examination, you did not show pinchability, number one, whether the swelling was fixed to underlying structures or fixed to the skin, fully mobile, partially mobile. You had no such comments. You have just said it is firm, non-tender, immobile. But immobile, is it fixed? We
Yes,
don't
sir.
know.
It is fixed, sir.
No, but that you have not demonstrated in your examination also, no?
Yes, sir.
So yes, are all these points you have to show also. That is why I had it was a good idea for you to upload that video. It is very essential for the students to see what is the correct technique, and I think everyone should go back to SDAS and see what has to be seen. Fine. So these are the things. So finally, if you will summarize your positive points and give me a differential diagnosis, Bhargav.
Yes, sir. A 39-year-old premenopausal female with no significant history presented with right-sided lower neck swelling since 3 months, sir, which is insidious onset and gradually progressed to present size. The swelling, which is firm, non-tender, and immobile. It was fixing to the underlying structures and the skin. It was 4 into 4 centimeters of swelling, sir, which is globular in shape, smooth surface with regular margins, sir. And
Was it transilluminating or it was solid swelling?
solid tumor, sir. It was a solid tumor, sir.
Okay, solid swelling, not a tumor.
Solid tumor.
Solid swelling.
Yes, sir.
Yeah. So, what is your differential diagnosis?
Sir, it can be a neck node, sir.
It is obviously a neck node, but what
Yes,
is the likely primary? Is it tumorous or non-tumorous? Firstly, so you
sir.
cannot just in a differential diagnosis tell me, sir, it is a squamous cell carcinoma of the nasopharynx. No, you
No,
have to
sir.
tell me what is because you don't know what is the biopsy, you don't
Yes,
know what is the scopy. Okay, so you have to accordingly tell me what is the differential diagnosis.
sir. The swelling is presenting over the right supraclavicular fossa, sir.
Mm-hmm.
So I may suspect any lymphoma, sir.
But you are saying it is hard
Hard.
fixed.
Yes,
Are
sir.
those points in favor of lymphoma?
No, sir.
Then
It may be a malignant neck node with primary under evaluation, sir. The primary may be from the breast, cervix, esophagus. Any GA malignancies can be, I can expect, sir.
so you are ruling out head and neck.
Finally, head and neck, sir.
Finally head and neck. Okay, so in a right in a anterior, this is basically an anterior supraclav. uh, it's a lower supraclav, no, going to
Sir.
the medial 1/3 of clavicle, no.
Yes, sir.
Medial
Yes,
1/3
sir.
of clavicle.
Yes, sir.
So is it so it is an anterior, basically it's an anterior supraclav node, uh, more anterior. So what is the percentage of, say, nasopharynx that will cause such a disease? Nasopharynx, what is the percentage could be a nasopharyngeal primary? What percentage of such swellings can be oral or laryngeal or hypopharyngeal primaries? Then esophageal primaries, lung primaries, huh?
Sir, percentages, I'm not that sure, sir, but if
Terence
any,
gives you na.
sir,
Esophagus, if it is, for example, if it is cervical or upper thoracic esophagus, around 20%, if I'm not wrong, around 15 to 25% of such swellings will be in the right or in will be in the supraclav.
yes, sir.
Okay,
Yes, sir.
then something below 20 to 40% of nasopharynx and 10 to 20% of hypopharynx and oropharyngeal swellings will be in the supraclav, in the lower neck, basically in the lower neck.
Yes, sir.
Then up to then in lower esophagus, even around 5 to 8% of such swellings will come in the supraclav,
Yes, sir.
even in the lower esophagus. Then lung also, depending on which part of the lung is involved, you will have a differential involvement of the supraclav and the lower neck. Okay, so you cannot rule out these things. Dr. Kanu, anything you would like to add? Then you'll have to add how many what is the percentage of tubercular swellings or
Hello.
any other granulomatous inflammations also. So yes, Dr. Kanu, please come in.
Yeah. Meaning your question is how many percentage of the things are the malignant from the sites actually, meaning hypopharynx,
Mhm.
pharynx or esophagus.
Mhm. So as I think Shelia has written over here in the chat. So yes, you have benign infections like syphilitic node, you have tuberculous nodes, then malignant, you have lymphoma, sarcoma, you can have paragangliomas. Then yes, squamous cell carcinomas of the head and neck, of the esophagus, of the lung, even breast primaries, all of this, even thyroid, breast, all of this, even stomach, you can have stomach also.
Yes, sir. Yes, sir.
So all of this can be the in various differential percentages you will have. So uh, then your viva can go on to any of these also, whatever your examiner is comfortable with.
Yes, sir.
Fine.
Yes.
Then there will be rare causes. So a supraclav can right supraclav you're saying. So typically a right supraclav swelling can come from your gallbladder, pancreatic swelling, or GI tumors. Fine,
Yes, sir.
or even lower down into the pelvis.
Okay, sir.
So those will be rare causes. Fine. So
Okay, sir.
anything can be there. Most common, if you say, will be head and neck. Uh, if it is stony hard, head and neck, uh, commonly nasopharynx, oropharynx, PFS, then lymphomas, then you will have thyroid or esophagus and
Yes.
lung as well as breast. These are most common.
Yes, sir.
That is for malignant. Non-malignant, tuberculosis most common, then syphilitic node, or you will have what is that? Granulomatous. You can put it in sarcomatoid illnesses, granulomatous illnesses.
Okay, sir.
Okay. So,
Yes, sir.
what are the investigations workup you will do for this now? Now that you know the DD, what is the workup you will do?
Sir, after complete history and physical examination, I would like to do triple endoscopy, sir. Followed,
Okay.
followed by is CCT neck, sir.
Hmm.
Followed by biopsy from the lymph node, sir.
So, won't you do a biopsy first? Okay. Endoscopy, triple
Endoscopy.
endoscopy, mucosal examination. Then biopsy, you will do CECT. So what is how many people will go for CECT? How many people will go for whole body PET?
Sir, according to guidelines, so according to ASCO guidelines, so initially we can do CECT neck, sir, to to find out any primary. So if the CECT neck is negative, then I can proceed with whole body PET CT, sir.
Okay. So CECT, you are saying head and neck. So what
Yes,
CECT?
sir.
No, that's what we are asking you. So CECT, what will you do? Head and neck, thorax, abdomen?
See, head and neck, sir.
Okay. Or okay, fine. maybe I would rather do a PET also, PET, a screening PET for the whole body. Then
Yes, sir.
anything?
Sir, after after sir, in according to guidelines, sir, after PET CT, so it is better to go ahead with pan endoscopy if any lesions are present in the nasopharynx and
So
pharynx and
directed directed biopsies from suspected areas,
areas can be easily.
endoscopy,
Yes, sir.
okay, and also PET. Based on the PET, you can identify areas at
So,
risk.
yes, sir. Yes, sir.
So, and also now the swelling itself. Would you like to do just an FNSE or a full excision biopsy or a true cut biopsy?
Sir, if the swelling is accessible, if the
Bear in
swelling,
mind, it isn't accessible. No, you said supraclav, and bear in mind, it is, you are saying that the skin is involved.
yes, sir. I would like to do core biopsy, sir, with IHC, sir.
So, okay, IHC is definitely you should do, but core biopsy would be a better option. Excision, I mean,
Underlying two structures.
that is bit
Difficult.
controversial because it's a 4 by 4 centimeter lesion. Skin is involved, fixed to underlying structures. Excision would likely just be partial excision.
Yes, sir.
Yeah. So, okay. Now that suppose you get it as a squamous cell cancer, your IHC confirms it.
Okay, sir.
Then it just says squamous cell, poorly differentiated squamous cell carcinoma
Okay.
confirmed by your IHC.
Yes, sir.
Now what will you do?
Sir, in IHC, I would like to do any HPV test, sir. HPV DNA test, sir. If
Okay.
if HPV DNA test is positive, I would suspect any primary in the oropharynx, sir.
Mm-hmm.
If HPV test is negative, I would like to do EBV test, sir.
Okay.
So if EBV test is positive, I would like to sir, I would like any suspicion in the nasopharynx, sir.
So how many days have passed now since you have been doing all this?
Sir, please, sir. I
So
didn't.
how many days would have passed by the time you're doing all this? Your please remember the first thing, your patient has come with an impending skin involvement.
Yes, sir.
Okay.
One by one. So I will do simultaneously all these things, sir.
Fine. So try to finish everything in a week to 10 days,
Yes, sir.
along with anti-inflammatory medication for the patient.
Yes, sir.
Now, if you think it is a head and neck primary, we'll go one by one. So if it is a head and neck primary,
Yes, sir.
suppose, okay, and
Yes.
you're still not sure about what is the primary. It is head and neck, but we have not found any primary.
Okay, sir.
Okay.
Yes,
Yeah,
sir.
pan endoscopy guided multiple biopsy should be done. So
Yes,
that
sir.
just one question has come. And yes, I have said no trial of antibiotics and anti-inflammatory I would give during the meantime. Yes, I would do that. So now we let us assume it is head and neck, okay, and
Yes, sir.
we don't know the this primary site. What will be your treatment? Non-metastatic, single node, 4 by 4, fixed.
Yes,
What
sir.
now? Now, firstly, what is your staging?
Sir, T0 N3B MX, sir.
Now the question is, why is it N3?
Because of the external extension is positive for this patient, sir.
Extranodal? How
Clinically
is it
fixed,
extranodal extension?
sir. It is fixed to the overlying skin and the underlying muscles are also involved, sir.
Good. Okay. But have you, what is the, how will you quantify extranodal extension?
Sir, the size of the node should be more than 3 centimeters, sir.
Okay.
Clinical.
And
And the node is immobile with skin fixity
fine. And
with
any radiological signs?
yes,
Anything you will do radiologically?
radiologically, I will see the if any irregular shape of the node and the capsule of the node is breached, sir. And if it is invading the adjacent structures,
So you have to tell me all that, no? So what are the signs of extranodal, and based on radiology, what is the probable grade of extranodal extension?
reading,
So for that, what investigation you should do?
sir,
MR.
MR,
Yes, I
yes,
think
sir.
someone has written MR. So it is MR you have to do. MR will tell you either it is MR or it is a grading of extranodal extension is based on either MRI or it is based on histopathology.
Yes, sir.
Fine. So since we have not done a full excision of the whole node and a histopath, so we will not depend on histopathology for the grading. It is the MR based grading.
Yes, sir.
Okay. So now what is the management of this case?
Sir, it is a stage 4B disease, sir. So uh, I would like to give definitive chemo RT for this patient, sir.
Is there any indication for neoadjuvant chemo or immunotherapy in this patient?
Sir, no, sir. No.
Hmm?
Sir, I didn't come across any neoadjuvant chemotherapy or immunotherapy guidelines as such, sir.
This is a controversial topic. People, there are trials which are saying that in neoadjuvant chemo followed by review for response. If it has responded, then surgery followed by chemo RT. Otherwise, definitive chemo RT.
Yes, sir.
So how will you say which is better?
Sir, I would say definitive chemo RT is better, sir.
Again, no head-to-head study.
Yes, sir. No head-to-head study, sir.
Your 323 and 324 studies only studied the chemo regimes.
Yes, sir.
So standard of care was neoadjuvant chemo followed by response assessment and look out for surgery if not possible, or patient not willing, or other biological factors not in favor, then CTRT. If also after surgery, if the histopath is
Sir, your voice is
amenable
not
for
audible,
chemo-RT,
sir.
then chemo-RT.
Sir, your voice.
Otherwise, am I audible now? Am I audible now?
Yes, sir. Yes, sir. Now it is.
Hello?
It is okay, sir. It is okay.
Okay. Am I audible now?
Yes, sir.
Everyone? Okay. Okay. So, Kanu, Dr. Kanu, anything from your side? Would you like to come in?
Sir,
Yeah,
sorry.
डॉक्टर आशुतोष
हाँ
हाँ बोलिए बोलिए
नहीं तो मैं तो बोल ही रहा हूँ. It should not be a one-way monologue, no?
yeah, no problem. So I think my treatment protocol will be based upon the ISC marker also.
So I think now Tata is running one trial on unknown primary of surgery followed by chemo RT versus definitive chemo RT. So
Okay.
it is still undergoing, it is still recruiting. So we have to wait for those results. But head-to-head comparison, we still don't have.
Yes. Head-to-head comparison is not there, but the treatment protocol will be depend upon the what are the ISC markers. Dr. Bhargav,
Definitely.
what ISC markers you want to do?
Yeah, that is also a good question. I've completely forgot about that. So yes, Dr. Bhargav, for say a typical squamous cell, what would be the IHC markers for a lymphoma and for an adenocarcinoma? If you could tell me these three.
Yes, sir. For P16, sir. For squamous cell carcinoma to rule out HPV, sir. P63 also a marker, sir, which can differentiate from the squamous and adenocarcinoma, sir. For tumors with any tumors with hematolymphoid organ, I would like to do CD45, sir. If I suspect any breast origin, sir, I would like to do GATA, sir. IHC GATA 3 can be a marker, sir. If
So
any,
can you go systematically? So first you will say you will do CK56 or CD 45, or you would like to do a P40, or for what is there for adenoma, a pan CK or a then ERPR marker and or a GATA for adenoma or adenocarcinoma, either breast or GI. So these are the five main families you would run. Okay.
yes,
Then
sir.
along each pathway, what are the further markers?
Sir, for squamous, P16, P40 and P63, sir.
P16, P40,
P63,
then P6, P
63, sir. 63.
yeah, P63 as well as
P4,
PDL1.
P,
Would you like to do PDL1?
no, sir, no, sir. PDL1 is somewhat, those are the for pembrol, for immuno, for to give immunotherapy, CPS, TPS score, that we will do, no, sir.
So nowadays your chemo medical medonc colleagues would be very much in favor of that.
Yes, sir, I don't know about those, sir.
Okay, no problem. So then what are the other markers? Say next for adenocarcinoma line, what one is GATA, one is what else?
TTF, sir.
TTF, good.
Napsin,
TTF
sir.
and
Napsin,
yeah,
sir. Napsin.
Napsin, TTF, GATA, and anything else?
CK7 and CK20, sir.
Okay, good. Then coming to the lymphoma family,
Sir, CD45, sir.
CD45, I would do CD45, CD15, and CD20 first.
Yes, sir.
Okay.
Yes, sir.
Based on this, we can subgroup our patient.
Big cell, yes, sir. Yes, sir.
Anything else? Then
Yes, 100 and socks for any melanomatous origin, sir.
good, good. So
Sir,
broadly, we know now what are the lines of IHC we should go ahead, isn't it?
yes, sir.
Then, if it is an adenocarcinoma, what would be your line of management?
Sir, if it is adenocarcinoma, I would like to go further into IHC, sir,
Mm-hmm.
with the NGS panel.
Well, you can tell me based on primary, based on each primary, how will you manage this patient?
Sir, if it is TTF1 and napsin positive, sir.
So you can tell me about the each primary based, because otherwise it will be very long. Okay, na? So tell me based on each primary. So if it is a lung, so this was a lung
Yes,
with
sir.
a very small primary tumor which you could not identify, and this large node. How will you treat?
Sir, if it is a lung primary, I would like to do first initially this NCCT thorax, sir, to rule out any lesions in the lung.
So we have done all that.
Yes,
As I said, no, we have done the investigation.
yes, sir.
So assuming now it is a lung primary.
Yes, sir. So I would like to do any NGS panel on the NGS panel, sir, for looking any EGFR, ALK and PDL1 status, sir.
Okay. Then
If it is a stomach primary, any
so yes, adenocarcinoma of the right supraclav fossa, isolated, a large volume disease in the supraclav
yes, sir.
would be quasi quasi-metastatic for esophagus and lung. So it is basically uh, quasi-metastatic. It's not a completely metastatic. It is the last non-regional node. Okay. Whereas for GI, it would be a metastatic disease. Fine. Except
sir.
cardia of stomach. Except cardia of stomach, it would be a metastatic disease. So
Yes, sir.
that is how you would treat. So in this case, if you are just having, you have found no primary. That's what I'm telling you. No, in your investigation, you have found no primary. It is an adenocarcinoma. So how will you treat? You cannot irradiate unnecessarily the whole lung or
Systemic.
the stomach or the pancreas.
Yes, sir.
है
Systemic.
ना? So you will give systemic therapy.
Yes, sir.
Will you also consider surgery for the node?
No, sir. No, sir.
Why not?
Sir, first I would like to do any systemic chemotherapy, sir. So
So
based on that
that
response,
I'm agreeing. So what chemotherapy will you use? What chemotherapy will you use?
sir, cis-etopo, sir.
Why? Cis-etopo. Okay, I was not expecting this one. So why? So you have to defend your question answer.
Sir, Paclitaxel usually for the squamous origins, we would like to give, sir. Sir, for cis-etopo is
Which paclicarbo is used? Where do you not use paclicarbo in adenocarcinoma lung? In ovarian tumors?
yes, sir.
Then then cis-etopo is classically used in which subset of tumors?
Small
Whether in the
cell,
lung, huh?
small cell, sir. Small cell of the lung, sir.
Small cell of the lung or any other variants? Neuroendocrine भूल गए? So it is typically for neuroendocrine tumors, either uh, VAC or cis-etopo.
Cis-etopo.
Cis-etopo is used either typically in small cell lung cancers or it can be also used in neuroendocrine variant of tumors. Okay.
Yes, sir.
So now considering coming back to our original question is, this is an adenocarcinoma. What chemo will you use? So a lot of people have given you choices. So yes, paclicarbo is correct. Pembro with carboplatin, maybe, maybe not. Then gemcite carbo is also a good option. Uh, then yes, either pacli plus carbo plus immunotherapy. Yes, we can. Okay.
Yes, sir.
Now, if it is okay, lymphoma, so we know it will be, what stage will this be in a case of a lymphoma? Based on your the findings that you presented to us. You should remember your original findings.
Yes, sir. Stage 1, sir.
Stage 1.
Yes, sir.
Sub 1 के बाद खत्म. After 1, what else?
Sir, it is not extending into any organ, airway organ, sir. That's why I'm telling stage 1, sir. It is
So stage 1, then is it lymphatic, extra lymphatic? Is
lymph.
it bulky, non-bulky? Are there B symptoms or non-B
Okay, sir.
symptoms? You have not put those?
Okay, sir. Stage 1 with no B symptoms, sir.
So 1A, no? No, it will be stage 1, non-B. It is a no B. So then is it bulky or non-bulky?
Non-bulky, sir.
Again, are you sure? You said it is more than 3 centimeter in size as per the latest classification, Deauville, I think, and the Lugano staging, as per the Lugano staging.
or I will refer one, sir. But bulky.
So there is different classification for bulky with respect to mediastinal tumors,
Yes,
with
sir.
respect to neck nodes. So the size will differ.
Yes, sir. Yes, sir.
Bulky or non-bulky, then extranodal, non-extranodal, with splenic involvement or without. All those things you have to tell me in lymphoma classification.
Yes, sir. Stage.
So I think we have got a lot of answers from people. Dr. Kanu, am I exceeding the time?
You can go ahead, no problem. Another 10-15 minutes is there with you.
Okay. Acha, 1 hour hai. Haan. So, Bhargav,
Yes, sir.
I think
Suppose-
he has forgotten to evaluate the EBV also, nasopharynx.
yeah. So we'll come to nasopharynx also. But abhi isme, see, nasopharynx, we suppose EBV positive hota hai, nasopharynx bhi hota hai if there is no primary site found and it's only the node, then treatment is definitive CTRT plus either chemotherapy before the CTRT or chemotherapy after the CTRT. Fine. So as per the latest classification, it is GEMSIS 2 cycles followed by CTRT for nasopharynx.
Yes, sir.
Yeah. Okay. So now coming to if it is for suppose it's a Hodgkin's lymphoma, how will you treat this patient?
Sir, it is a stage 1 disease, sir. I would like to go 2 cycles of ABVD, sir.
Okay.
Then PET evaluation, sir. I would like to do
Fine.
PET scan, sir. If there is
Mhm.
if there is a response to the disease, so I can give one 20 gray of RT, sir, to the involved node.
Good.
Yes, sir.
20 gray of 20 gray. Sure.
It's a stage 1 disease, sir. Based on the
Stage one,
DPD,
and it has, is if it's responded completely, then hello.
if it is responded only, I will give it the 20 gray, sir. If it is not responsive, any residual is present, I would like to give 30 gray, sir.
Okay, fine. But if it is non-bulky, will you give RT at all?
If it is non-bulky, sir. One
Hmm.
cycle of ABVD, I will try, sir.
So I think you refer to the German lymphoma group 10, the 10th G10 and the Australian recommendations, which are, I think, the latest, fresh, as well as the ILROG. Okay, so suppose we do decide we are going to give RT to this patient. Okay,
Yes, sir.
then how will you contour your GTV, CTV, and PTV?
Sir, as we know, this patient underwent a PET scan, sir, initially, but that is not the planning position, sir. Sir, I would like to do involved site RT, sir, rather of involved node RT.
What is the recommendation? ILROG.
So if pre-chemo, if the patient is not in planning position, sir, planning PET position, so INRT involved node RT is not recommended, sir. Involved site RT is recommended, sir.
Okay.
And so there is after chemo there is CTV, sir. I would like to contour the initially involved region, sir. Then 1 to 1.5 superior inferiorly, sir. I would like to treat, sir.
What? I'm sorry, I didn't get you. Hello.
Sir. Yes, sir.
Huh. I didn't get you.
Sir, it involves site RT, sir. So my CTV will be the initially involved node, sir. Initially involved node place with 1 to 1.5 centimeters margin, sir. Superior inferiorly.
So post chemo will be the GTV or pre chemo will be your GTV?
Sir, there is no GTV, na, sir.
So there are two things. One is your tumor completely resolves
Yes,
post
sir.
chemo.
Yes, sir.
So you have a CTV only. Then,
Yes, sir.
in fact, your choice is fairly simple. I would use probably the pre chemo GTV as my CTV.
Yes, sir.
Okay.
Yes, sir.
Now, but if there is a small residual, it has responded well, and there is a small residual, and you have added extra chemo also, and then you are going in for RT. But there is still a small residual disease. What is your GTV? Is your post chemo disease, or is it going to be still your pre chemo extent?
Post chemo is my GTV, sir.
The consensus, everyone says pre chemo and edit for your tissue planes.
Yes, sir.
Okay.
Yes, sir.
We still have a few studies going on for that now. So I will not definitely say it. There are some institutes which will go in for a GTV post chemo, but add the pre chemo volume as your CTV and edit it for the facial plane changes, and then add the PTV.
Yes, sir.
Okay,
Yes, sir.
so it works both sides. It works both sides.
Okay, sir.
Then what technique will you use? Simple 3D CRT? It was a 3D supraclav, or will you go in for IMRT, VMAT, advanced techniques?
Sir, I want to do VMAT and IMRT, sir.
Why?
Because in CT I can contour my node and I can modulate my.
Who says for 3D CRT you can't contour the node on a
Sir,
CT scan?
I can do, sir.
Huh.
But nearby structures are there, sir. So this is a patient of breast, sir. So if I do 3D CRT, the breast dose may be increased, the spinal cord dose may be increased, and I can give radiation to the thyroid, sir. So it may cause any radiation induced
So I
thyroid
wish
nodules.
I wish I could show you on the CT scan on this instead of all of us talking abstract. So everyone has said IMRT, IMRT, VMAT, spinal cord proximity to critical structures. What if I say that 3D CRT in this particular case is as good an option? Why? As IMRT.
Sir,
With IMRT, in fact, you were trying to protect the thyroid and breast. A large volume of that would get a intermediate dose. A low to intermediate dose will receive a large portion of the body will receive an intermediate dose. Next, your brachial plexus is the main OAR in that area along with the spinal cord, but you're only going to give a maximum of 30 gray,
yes, sir.
well within the tolerance of each.
Yes, sir.
Okay. Thirdly, your integral body dose would be much lower with a 3D CRT in this particular case. So I'm not saying it is across the board. Everywhere it is not the same. But some places 3D CRT is a better option than IMRT. Let us all, I mean, to all the students, don't automatically go for IMRT, VMAT because it is a newer technique. Sometimes the older technique works better. So integral dose would be much higher in IMRT. So your mu values per field your field for IMRT, if we are not using VMAT, would be of the order of 4 to 5 times compared to your 3D CRT. Fine.
Yes, sir.
So since we are also Hodgkin's lymphoma, we are talking of, yes, the last Shelya has made a very correct point, as we are talking of long-term survival. So a higher integral body dose would have a higher rate of secondary cancers later on, as well as um, thyroid deficiencies or heart problems also.
Yes,
So
sir.
yes, now the integral dose with VMAT compared to IMRT. See, area-wise, if you see area-wise, it's not much difference, but in IMRT, the the area receiving the intermediate dose is higher compared to the area receiving intermediate dose. Intermediate doses are basically your 40 to 80% isodose curves. So low dose would be less than the 35% isodose curves. Anything between that and 75-80% is your intermediate, and above 75-80% is your higher isodose area. So the intermediate dose areas are higher in IMRT, and since the MUs are also higher, so expected integral dose body dose is more in VMAT. Sorry, more in IMRT. However, in VMAT, your skin doses are higher because the beams are not perpendicular to the skin or at the point of entry, they are more tangential. So up to up to 20% higher skin dose is seen. Usually it is between 12 to 18%, but up to 20% higher doses are also noted for VMAT. Okay.
Yes, sir.
Someone has said missing out in IMRT. Now really I don't think in a supraclav swelling there will be chance of a miss because the movement of the tumor would be less. So the chances of miss would be more maybe in the mediastinum or inside the abdomen rather than in the the supraclav area. Okay.
Yes, sir.
Yeah, yeah. So I think we have covered most of the points. Yes, this is a vast topic, and I mean we can keep talking on it. And
हाँ
Kanuji,
हाँ बोलिए बोलिए
should I close it here?
Okay, no problem.
So
Yeah,
any points the students feel I have not covered?
yeah, students, anything you want to ask or something, you get it clear by
So
starting from the
summarize.
history taking to the examination.
So yes, there's been an important point: skin to be treated here. Skin sparing needs to be avoided. So yes, during RT if we are giving RT upfront, so bolus has to be put on the skin and skin sparing. So can the students tell me if I am not using a bolus, if I am using a IMRT or VMAT or a 3D CRT, what is the usual isodose covering the skin for a 6 MV Linac?
Sir is asking something.
So how much, which isodose covers the skin?
90.
Everyone is taking a chance. Everyone is taking a chance. Actually, it is 65 to 70%. It is 65 to 70% isodose curve at the skin. 30%, though it's not at all, no. So, in case I am using a 6 MV Linac, if I'm using a cobalt, then it is 75 to 80%.
Yes, sir.
Okay. So
Yes, sir.
last question they had asked, okay, which 1 minute, which is PET CT, biopsy, pan endoscopy. I would say pan endoscopy, biopsy, and then PET CT.
Yeah, So if it is a meaning better to do a biopsy first, endoscopy, but pan endoscopy and biopsy first, later do the PET CT if it is a accessible lesion. Because according to the need, if sometimes it comes as a tuberculosis, why we should go for a PET CT? Yes, Dr. Asutosh, what is your take?
Yeah, I agree. And someone has asked use of tongue depressor to see oral cavity during oropharynx. Yeah, if you are inspecting, if as long as you are not palpating, it is still inspection. You can use a tongue depressor. Inspection doesn't mean that you can't touch. No.
Yes.
And SUV value. No, but why you want to do? Someone has asked tonsillectomy, but why do we want to do tonsillectomy?
See,
We
there is
don't
a
know.
no role of tonsillectomy.
N3 disease.
N3 no, N3 whatever may be, no role of blind surgeries.
No role of blind surgeries.
You can then do blind nasopharyngectomy. These are things, old things where no PET CT era.
So I think this case, Bhargav, if you can provide a summary to everyone later on or now only.
I will give, sir.
Yeah, sure. Thank you so much. And thank you everyone for the lovely questions. Also, it's always good to have people questioning you so that we are always alert.
So thank you, Dr.
So many
Asutosh.
questions coming up. Now, these are specific practice points post lignocaine to avoid gag reflex and all. So each person will have their own way of examining. Okay, thank you.
Sir, someone is asking this question, sir.
Last question, sir, mucosal irradiation, how much dose should you give usually? So somebody is asked what is the mucosal irradiation. So in the older days, starting from the nasopharyngeal mucosa to the hypopharynx mucosa, we even including the post-cricoid area, the all mucosas to be irradiated. But in the PET CT era, I think most of the
This is actually still a controversial thing. A lot of people still use whole mucosal irradiation with a local boost. They still use it with IMRT. So if I am going to do it, I would not go beyond an equi-D2 of 50 gray, 50, 51, not more than that. Now, even there, I would be careful for the constrictors. I would be careful for the DAR structures. Kanu?
Yes, sir.
And your take, you would probably only follow the PET, huh?
I will probably PET, but if
3
there is
centimeter margin to PET.
PET scan uptake, you are telling for the nodal uptake?
Yeah. 3
Hello.
centimeter
You're
mucosal margin or 1.5 margin tissue margin around the PET. Hello?
For node alone?
Hello?
For
the node?
So you will see, it depends upon the extranodal extension. I will give the node for boosting area.
No, definitely node will be boosted. How mucosal irradiation, how much will you do?
Mucosal irradiation.
Yes, sir.
Still, it is a controversial. If
I agree.
I
agree.
So usually subclinical volume should go to about 50 gray, but when the lesion is not known properly, then I will go to 59.4 or 60 gray, but it is slightly controversial. There is no clear cut data.
So our department policy is we give 54 and 30, which is equivalent to around 52 gray, 51 or 52 gray in equi-D2.
Yes, sir.
But at the same time, sparing the DAR structures.
Yes, DARs and moist structures.
Yes. Okay, thank you everyone then.
Thank you, Dr. Asutosh, for joining with us. We are very delighted, and thank you very much. Thank you.
Okay, thank you everyone.
So our next topic will be ASCII chemotherapy. And who is the ASCII chemotherapy? So it will be taken the moderating the question answer asked will be asked by Dr. Murtunjay Rao. He is from Mahatma Gandhi Cancer Hospital, Visakhapatnam. He is a senior consultant, and answer will